network. I can see here ADCH connected. ADCH team, good afternoon. We have Chipata Centro.
Good afternoon, sir.
Thank you. Thank you. Welcome. We have as well Chipata Centro Hospital on the network. Chipata Centro, good afternoon.
Good afternoon.
Thank you. You are welcome. We can see as well St. Francis Hospital. Team St. Francis, good afternoon.
Afternoon.
Thank you. You are welcome to this echo session, which we are having on the 3rd of October 2022. A very interesting discussion and learning session, which is going to be conducted today. And your presence to this meeting is actually valued. So let's stick to the echo etiquette. You raise your hand when you want to chip in, and in a situation where the presentation is going on, kindly utilize the chat box. We have already posted the link. Ensure that you register your presence to this particular meeting. We have actually subject experts on the subject matters. For today's topic, we are actually expecting Dr. Loti Hachambwa. Loti, if you are on the call, good afternoon, Doc. We are expecting as well Dr. Sokolo Bright. Dr. Sokolo Bright, another expert on the subject matter. Dr. Sokolo, good afternoon. We are also expecting Dr. Efford Sinkala, another expert on the subject matter. Dr. Kawana Wamundila, Dr. Rokaya Ngiwala. These are the experts on the subject matter for the topic we are discussing today. So our didactic presenter is Dr. Michael Vinica. Dr. Michael, if you're on the call, please kindly introduce yourself.
Hi, doctor. I can hear you. Can you hear me?
Yes, we can hear you, Dr. Vinica.
Thank you. Thank you for inviting me to give the presentation, the didactic. Dr. Mike Vinacore. I'm an infectious diseases specialty doctor, and I've been working on hepatitis in Zambia for 10 years now with several different institutions, including UTH, AIDC, and the UTH HIV/AIDS program, and CIDERS, and University of Alabama at Birmingham in the US. Thank you very much.
Thank you very much, Dr. Michael Vinica, for this wonderful presentation. I'm your facilitator for today's presentation. I'm Dr. Emmanuel Mungomba, HIV/TB medical mentor for Lusaka Provincial Health Office. With me here at the hub, I'm with a very powerful team assisting us to reach you wherever you are. So this actually is a great day. Dr. Michael Vinica is going to actually present the topic and have the presentation started. Once more, team, let's follow the echo etiquette and let's ensure that we raise our hands and will be given an opportunity to talk. Then whatever issues which we have, we can as well utilize the chat box. So after the didactic presentation, which is going to be done by the didactic presenter, who is Dr. Michael Vineca, and as well the expert on the subject matter, we are going to again have the poll question, then we'll enter into the case, which will be made available to us by the UTH team. So once more, thank you very much. Dr. Vineca, we can have the presentation started.
Okay, thank you so much. And it's wonderful that so many of you have joined. I hope you learned something new today about hepatitis. And the topic is integration of hepatitis treatment and care into ART programs. And I'm here also representing the Accelerate program, which is a program, a funded program at UTH HAP to help accelerate the progress towards hepatitis elimination in Zambia. Next slide, please. So our learning objectives this afternoon are to identify and recognize efficiencies that will facilitate natural integration of hepatitis into HIV programs. Number two, to recognize areas where things are a little bit different between hepatitis B and HIV. Things that we have to be aware of as we do integration so that we can make sure that things go smoothly. And third, to learn about successful integrated care models. And I hope at the end of this presentation, you'll go away with a lot of confidence that you'll be able to integrate at your sites. There are going to be more emphasis on hepatitis in the coming years. I think that as a program, we've been stalled because of COVID, of course, but as COVID numbers go down and a lot of our experts can now shift their attention to other conditions, I think we'll be seeing more and hearing more about hepatitis. And I think hopefully on the basis of this presentation, you'll recognize how it will be very straightforward in many ways for you to start treating hepatitis and preventing it at your facilities. Next slide, please. So this is the data that were generated in the first Zamfia, which took place in 2015 and 2016. So you can see from this that HIV is still a more prevalent condition than hepatitis B. So at that time in HIV, we estimated about 1 million cases. And for hepatitis B, it was around 540,000 cases. And you can see that there are patients with hepatitis B alone represented in the top blue circle. There are patients with HIV alone in the green circle. And then there are patients who fall in between both, what we call co-infection, HIV, HBV co-infection. And we have a lot of cases of HIV, HBV co-infection. You can see in Zamfia, they came up with an estimate of 72,000, which is quite a large number. And these are usually the sickest patients that we have with hepatitis, because it's very logical that having two infections at the same time is often worse than just having one. And so we even see that clinically. And when we talk of hepatitis B and people with hepatitis B, we're speaking of one specific test, which is called hepatitis B surface antigen test, or HBsAg. And so that is the clinical test for hepatitis screening and treatment. And so I won't go into the various different forms of hepatitis testing today, but just to say that that is the most critical one. It is the one that most of you have experience with in your facility, in your laboratory. If you go to your laboratory today or tomorrow and you ask them, they'll have the surface antigen test there in your lab, most likely. Next slide, please. So the first thing I wanted to say about testing is that it's going to be quite straightforward in Zambia, and it's already straightforward because, as you can see here, one of our counselors at UTH, she was actually able to run 3 rapid tests using 1 finger prick drop of blood. So as you can see, just like in HIV where we have finger prick blood testing, such as Determine, Unigold, others. We also have this for hepatitis B. And so when we are ready to start integrating at a high level, when you have supplies and materials and everything in place, I think cross-training your staff to do the integrated testing will be very straightforward. The one difference I want to highlight is that we don't have a self-test for hepatitis B. Many of you know about these self-tests where a patient can even swab their own mouth and their saliva and test for HIV. Unfortunately, hepatitis B, it doesn't end up in your saliva, and neither do the markers. And so we don't have such a test. So it will require at least 1 drop of blood to do a hepatitis B test. But this is obviously a huge benefit for us as a country, that just as we're doing an HIV test, we can easily do a hepatitis B test as well. Next slide. Can we go to the next slide, please? Thank you. And the other thing to point out is that hepatitis B testing can easily be integrated with index testing. So I know that there's a large push to do index testing within the HIV program, and that's a good opportunity to also do hepatitis B testing. And with hepatitis B, there is one big difference, which is that the virus can spread in families. It doesn't require necessarily sexual transmission or sharing of unsafe needles in certain key populations. There's a much broader group of people at risk. And here on the right is a picture of a family that we recently got involved with at UTH, where we managed to test 3 generations of the family. You can see the circles represent the women and the squares the men. And so you can see at the top middle, the first person found was a woman who came for treatment of hepatitis B. And when we went to test her husband, represented in the square to her left, he was negative. But we also tested her brother and her sister, and one of them, her brother, was also positive. Then we informed her that she needed to have her children tested. And so we were able to test 5 of her children, and you can see that 2 out of the 5 were red, meaning that they had hepatitis B. And one daughter actually had one of her children also living with hepatitis B. And so the point we wanted to make is that the virus spreads in families, kind of from mother to child or between brothers and sisters, especially among people who haven't been vaccinated. And so when we do integrate, we're going to try to take a family-centered approach, the way we, I think, do a lot of times in ART programs. So we go beyond just index testing to a family-centered approach. Next slide, please. So testing is obviously, there's a lot of opportunities for integration, but here's the other huge opportunity we have for integration in Zambia, which is that HIV PrEP is HBV treatment and vice versa. HBV treatment is also HIV PrEP. And so if you've attended some of our previous ECHO sessions, you may have remembered that tenofovir-based therapy is the best treatment for hepatitis B. And this is, of course, the same thing that we're using for HIV PrEP. So those of you who are doing PrEP programs or key populations work, you're giving out a lot of TDF to your PrEP clients or your key pops. And by doing that, you're also potentially treating or preventing hepatitis B. On the right, you can see that the hepatitis B virus infects the liver once it gets inside the body. The liver is that pink organ on the bottom. And once inside of the liver, it goes inside of a liver cell and it uses the liver cell reverse transcriptase to make new daughter viruses. And if a person is taking tenofovir, that step of the life cycle of the virus is blocked. And so basically, when you do treat someone for hepatitis B monoinfection, someone who's HIV negative, you're actually keeping them HIV negative. And this is a huge benefit to the client. So they get 2 benefits, the treatment of their hepatitis and prevention of HIV. And by the same token, if you have a key population for HIV and you prescribe PrEP, you will be keeping them safe against hepatitis B, which can be sexually transmitted and transmitted through exposure to needle, blood, and other forms. So this provides really synergy, and it really will facilitate very well our integration. And the other thing, of course, that's a huge benefit is that most of you have a lot of experience with tenofovir. You know the side effects, you know the benefits, and you know how to treat people who are adolescents, adults. You have a lot of experience, and that medication is found in most of your pharmacies. So when we do offer testing, this way we'll be able to offer treatment immediately because we have that experience and we have those medications already in Zambia. Next slide. Now, the next slide is about mother-to-child transmission of hepatitis B. And so I want to bring this back to HIV. So soon we're going to be moving as a country into triple elimination approaches where we try to eliminate not only HIV and not only syphilis from mother to child, but also hepatitis B. So I just wanted to bring to everyone's attention where we are now and where we hope to go in the next 7 to 10 years. And so you can see that before the Ministry of Health introduced the vaccine for babies ages 6, 10, and 14 weeks through the EPI program, our mother-to-child transmission was estimated for hepatitis B at 17%, quite high. And it was already by that intervention was cut down to 9.5%. So we know that babies who are born after the vaccine became available in 2006, their mother-to-child transmission is at 9.5%. So this is where we are now. And so now as we adopt triple elimination, our goal as a program, as a country, will be to cut that down to just 2% mother-to-child transmission by 2030. That's our elimination target. And so you can see that our current vaccines are very effective, but we need new interventions to get it down from 9.5 to 2%. Next slide, please. And I'll talk about some options for how we're going to do that as a program and where we can integrate. So this is the incremental approach to preventing mother-to-child transmission of hepatitis B. And there are 3 main strategies that are recommended by World Health Organization, and we're now moving towards adopting these in the near future in Zambia. And at the bottom of this pyramid is actually HBV birth dose vaccination. So that's the idea of giving all babies born in Zambia an extra dose of vaccine right away when they're at birth. This would probably need to be given in the labor ward. We can't wait for a birth dose. We want to give it before the baby even goes home or as soon as possible in case it was a home birth. We don't want to delay until they're a week old or a month old. And so that is really the pillar, the fundamental pillar of this approach. But in some respect, it's going to be a little bit harder for us to integrate that as a country because the facility would need to start stocking this new vaccine and get experience using it. And we would need to have collaboration between labor ward, EPI program, outpatient. And so we would also need to have our vaccine cards reprinted so that the under 5 card can capture this. So it's going to be a little bit harder for us to implement that, but that is something I wanted to bring to everyone's attention as it will be probably coming in the future. But there are 2 other easier things that we can do. One is to screen moms. So it'll be very easy for us to do screening because during antenatal care, you already screen about 99% or 100% of moms for HIV. So you could immediately adopt the hepatitis B testing, and then you'll be able to identify those moms who could possibly transmit to their babies. And you could document the results on the antenatal cards, just like you do for HIV and RPR. And another possibly easy intervention would be to give these moms tenofovir. So to give it to them for prophylaxis, the way we used to give ARVs for prophylaxis for HIV. Before we had the Option B Plus program, many of you will remember we used to give moms some ARVs just to cover their pregnancy and postpartum period in order to interrupt transmission between them and their babies. And so this would be relatively easy in Zambia because we already stock these medications, we have experience using them, and we can bring in the testing for the moms relatively easily. So this is the approach to cutting mother-to-child transmission down in the future. And I think that there are obviously opportunities for our PMTCT programs to start integrating hepatitis B once we're ready. Next slide. And then here's just a summary of the care model when a person does test positive for hepatitis B. So just like in HIV, the first step is enrolling them in the clinic, giving an ID number, issuing them a card like a smart card or a paper card, doing a locator form so that we can trace if necessary, giving counseling and health education. And then just like in the HIV program, we also usually do baseline blood tests. Now we do the CD4, and we have to, of course, we have to screen for advanced HIV these days because it's still there with us. So TB screening, we do crypto screening. And so baseline blood tests are also part of hepatitis B care. But the major difference is eligibility. So in eligibility, we have to do eligibility assessment in hepatitis B because not everyone's going to be eligible for lifelong treatment. Whereas in HIV now we have universal treatment. So that is the one big difference. Once someone is given treatment with ARVs, as we mentioned, that they're the same, almost the same ARVs for hepatitis and HIV. So that's obviously very straightforward for most of you. And follow-up is very similar. So just like an HIV clinic or an ART clinic, we need to follow up the treatment monitoring. We have adherence, we have retention, all of these indicators that you guys are already tracking and strategies you're using and identifying the patients who are struggling. You would be using the same strategies when you have hepatitis B treatment as HIV. So the main difference I want to emphasize is that on eligibility. We won't have universal treatment for all in hepatitis B. There will be some degree of eligibility assessment. Some will be eligible and others won't, and then they'll just be followed up for eligibility in the future. Next slide. All right, I think this is back to you, Doctor.
Thank you, Dr. Michael Vineka. So we are going to go to poll question number one. So the question reads, integrating HPV into Zambian HIV program will be strongly facilitated by which of the following factors? Integrating HPV into Zambian HIV program will be strongly facilitated by which of the following factors? A, HBV treatment is already available at most Zambian public health facility, at most Zambian pharmacies. We have an established HBV chronic care model that is decentralized and reach nearly all people living with HIV in Zambia. 3, our HIV program is well performing, reaching or exceeding the 95 indicators. 4, all of the above. So far, we have 82 votes out of 281. We have some 20 seconds. Okay, so we are at 150. There is actually good participation, so let us vote. Okay, so close the poll in 5 seconds. We're at 164 out of 281. So I'll end the poll here. So Dr. Vineka, so here we have 64% feel that all of the above is actually the correct answer, followed by B, where we have an established HIV chronic care, where we have 19%, then A with 9%, and the last is 7% for C, for those who have voted for C. So kindly highlight more on this one, Dr. Michael.
Thank you. No, I think people did well. So all of the above are factors that will strongly facilitate integration in Zambia. I would say that a group of us are just getting back from a conference in South Africa about integrating hepatitis and HIV. And we could see that Zambia is actually in a better position than many other countries because of all of these factors, because we've already getting very close to all the 95s with our HIV care, and we have so much experience and high retention that compared to many other countries which will really struggle to integrate hepatitis. I think we can go to the next slide. Thank you. Okay, so I do want to talk about the issue of eligibility. We talked about this on previous calls, but this is the one big difference between treating hepatitis B and HIV. We don't have universal treatment in hepatitis B. We need to use eligibility the way we used to in HIV. I'm sure some of you are as old as me, and you may remember the days when we used to do eligibility assessments. And then we would tell clients, you're not eligible yet, come back after 6 months. And some would be eligible later, some would be eligible sooner. So in a client with hepatitis B who is now linking to your clinic and enrolling, there's a minimum laboratory package that is needed. So you really need to have these in place so that you can assess the eligibility. So these are, there are 3 main tests. So first of all, HIV testing must be there. Because of the issue of co-infection being so common, we require anyone with hepatitis B, we must know the HIV status before we decide on eligibility. Can you go back 2 slides, please? The second one is the full blood count. So within the full blood count, the platelet count can be a useful sign of a chronic liver disease, also known as cirrhosis. So if we have a client who has hepatitis B and they're HIV negative, and you see a low platelet count, that for us is a sign that they should go on to ARVs sooner. And the third important test is the ALT. So the ALT is a sign of liver damage and liver inflammation. And when it's persistently elevated, this means it's been elevated at least twice on 2 assessments. Those patients will be at high risk to get liver cancer or cirrhosis as a complication of their hepatitis B. So these are patients where we would start treatment earlier. And so if your facility can provide these tests, then they'll be very able to assign eligibility to people with hepatitis B. Next slide. So we have a little ways to go before we can really fully integrate because of some gaps in the laboratory area. So we recently did a survey of 31 facilities in 4 provinces, and I won't go over all the facility names and do any comparisons by province or by the level of facility, but this is just to provide you with a snapshot of what's happening in the real world. So you can see here that on the day of our survey, 100% of the facilities had HIV testing in stock and available. So if someone walked in and needed a test, they would have it. 61% had syphilis RPR testing, but only 41% 41.9% had a hepatitis B test. So we know that one of your barriers to integrating hepatitis fully is testing kits. And the other thing is that we looked at those labs, which we want you to have so that you can manage a person who's hepatitis B positive. So you have no problem with the HIV testing. That's very straightforward. But we could see that only some facilities, 68%, had a full blood count that was working on the day of our survey. So, we will need some alternative strategies, or we'll need some additional capacity building in that area so that you can manage hepatitis B. And also the ALT test was only available at 38.7%. So again, as we move towards integration, we're going to be focusing on building up the capacity or developing some strategies that you can use to manage patients with hepatitis in case these tests are out of stock. But we know that in the past, HIV tests, of course, they also had times when they were out of stock. And so as a program, nothing is always 100%, and we find alternatives, and you can see how far we've come in HIV, and I think we'll be getting there in hepatitis as well. Next slide. And then finally, I want to talk about our integration experience at UTH. So in the last 12 months, we have started a pilot integration project, integrating hepatitis into HIV clinic. And after meeting with AIDC and talking among the hospital administration, we decided to integrate with a 1 day a week approach. So we decided that 1 day per week, which was Fridays, will be our hepatitis clinic day. And we had to develop some new forms to manage the patients, and new files and new registers, because at this point, Zambia, we don't widely have specific hepatitis forms or registers. It's not an indicator that we're already capturing. And we also don't have a specific module in Smart Care, although the OPD module can be used. And then we also trained and built capacity in the health workers. So we had existing doctors who were already working on site to rotate through the facility, and nurses too, and pharm techs and pharmacists, just to gain experience seeing the clients and understanding the issues and seeing the similarities and differences from ART. We use the established infrastructure such as the pharmacy for ARVs, the bleeding room for collecting labs, the existing registry for storing files. And we also use existing laboratory platforms. We didn't have to buy any new laboratory machines because the facility already had a machine for the full blood count and the ALT. And so, so we recognized that that was an easy thing. We didn't need to come in with new machines. Next slide. Yeah, and so we were able to gain a lot of experience from this program. I think at this point, over 400 clients have enrolled, and we're just now analyzing our data and writing some reports so that we can inform Ministry of Health and even other regional partners in this region of Africa. And you can see that we also identified some gaps that we now know going forward will be things that we would need to think about when we integrate. So for one, you can see that from the point of enrollment, the first bar on the left, to the lab testing for eligibility, there's a drop off. So we weren't actually able to completely assess eligibility in every patient. About 15 or 20% didn't get their lab results into their file. And so the clinicians were unable to really say, is this person eligible or not eligible? So that's going to be something that we need to pay a lot of attention to as we go forward with integration. In HIV, of course, it's universal. So even if you're out of stock on your CD4, you can still initiate a patient. Or if you're out of stock on your creatinine, you can still initiate a patient. So in hepatitis B, we may need to take some approach like that. Because 20% of the time, even within UTH, we didn't get a complete laboratory assessment for eligibility. And then the other thing we noticed was how many were eligible. So you can see that only about 1/3 of the people where we did do eligibility were eligible on their first visit. So that means that the other 2/3 of people will need to be retained in care regardless and be reassessed for eligibility after 6 to 12 months. And so it was good for us to see that more than half the patients, they weren't eligible the first time through. And so as a country, we'll have to use all of our best retention strategies that we used to use in ART to keep people in care, even if they're not on ARVs. And then finally, we recognized that some who were eligible never initiated. And this was very concerning because once someone is eligible, it usually means that they have significant liver damages and high risk for getting cancer or cirrhosis. And so some of the times it was that the lab results were in the file, but the client didn't come back. Other times, this was just due to health education. So there were clients where we encouraged them to take ARVs for their hepatitis, but they weren't ready, or they felt uncertain, or they were worried about stigma in the community. They needed to discuss with their family members. And so there's going to be a need for increased counseling and training so that you can explain very well and even raise awareness in the community so that people are ready to go on treatment when they're found eligible. But again, I think we're in a very good position to do this as a country because we've done all this already when we were scaling up HIV treatment. We know there were people who weren't ready the first time we offered them ARVs. And I think it's a similar kind of story here in hepatitis. Next slide. And I think that could be my last slide. I'll hand back to Dr. Ngombe.
Thank you, Dr. Vineka. So this is our poll question number 2. Which is significant, this difference between HIV treatment and HBV treatment? 1, HBV treatment, ARVs don't prevent transmission to others. 2, in HBV treatment with ARVs, there is no need for adherence counseling. 3, many clients with HBV are not eligible for ARVs. 4, in HBV treatment, we use special ARVs that are not yet available in Zambian pharmacies. So I'm going to launch the poll. Okay, so okay, so the poll is launched, so we can start giving our responses vis-a-vis to the question which has been asked to us. We have 30 seconds to go. And so far, 40 participants out of 294 have provided their responses. So which is a significant difference between HIV treatment and HBV treatment? So you have in HBV treatment, ARVs don't prevent transmission. B, in HBV treatment with ARVs, there is no need for adherence. And in 3, many clients with HBV are not eligible for ARVs. In D, in HBV treatment, we use special ARVs, which are not yet available in Zambian pharmacies. 15 seconds to go. And so far, 140 out of 300 responses, which give us 46%. We have 10 minutes to go. Okay. So far, we have 53% participation. So we are ending the poll here. So on the responses so far, we have A leading with 49%. Most of the participants, Dr. Michael, believe that in HBV treatment, ARVs don't prevent transmission. And that is followed by C, where we have 43%, where we are saying that many clients with HBV are not eligible for ARVs, followed by B, where we are having 5%, and D with 3%. Dr. Michael, kindly highlight more on that.
Thank you so much. So I mentioned there are a lot of similarities and only one major difference between treating hepatitis and treating HIV. And the one difference is on eligibility for treatment. So as I mentioned in the AIDC in our pilot program, we found that many clients with hepatitis B who were HIV negative, they were not eligible for ARVs during the first assessment. So option C was the correct answer, but let me talk about option A. So the treatment and the prevention piece. So in HIV, we know very well treatment is prevention. You know, U equals U. Undetectable equals untransmissible. Well, it's the same for hepatitis B. So treatment is also prevention of hepatitis B, and U equals U for hepatitis B as well. So that's why the A was not the correct answer. So the correct answer here is the major difference as we go into integration is going to be the need to do eligibility in people with hepatitis. Thank you very much. And I think that was my last slide, or maybe I'll have one more. Passing back to you, Doc.
Thank you, Dr. Vinica. Okay, so that was the end. We have seen some good interaction in the chat box, and we have also some responses so far, which is actually very interesting. We are going to go back to the poll questions. Then after that, we are going to tackle all the questions which we're having in the chat box. So poll question number 1, just for us to make sure that learning has occurred. Okay, so this is our poll question number 1. Integrating HBV into Zambian HIV programs will be strongly facilitated by which of the following? Integrating HBV into Zambian HIV programs will be strongly facilitated by which of the following? A, HBV treatment is already available in most Zambian pharmacies. B, we have an established HIV chronic care model that is decentralized and reach nearly all people living with HIV in Zambia. And C, our HIV program is well performing, reaching or exceeding the 95 indicators. D, all of the above. So I'm going to launch a poll question just for us to make sure if we have transferred knowledge. "45 seconds to go." Dr. Vinica, we have 88, which is giving us 30%, and the answers are tailored towards one response. So far, we are at 40% now. And we are remaining with 15 seconds. Okay, so we are still active to make our vote, and we're at 46%. Okay, so we can end the poll here. Okay, right. So, Dr. Michael, so this is the feedback we are having. We are having 87% who believe that all of the above is actually appropriate for the question which has been asked, followed by answer B, where we are having 9%, and 3% for A, and C with 1%. So, Doc, please kindly clarify on that one.
No, I think this is this shows that there's been learning. People recognize these are all important factors to help us integrate hepatitis B. So don't think I need to give any more feedback on that.
Thank you, thank you. So we'll go now to our poll question number 2. So poll question number 2 reads, which is significant difference between HIV treatment and HBV treatment? A, in HBV treatment, ARVs don't prevent transmission to others. B, in HBV treatment with ARVs, there is no need for adherence counseling. C, many clients in HBV are not eligible for ARVs. D, in HBV treatment, we use special ARVs that are not yet available in Zambia. We have 1 minute to go. Fifteen seconds. Okay, so we are in a good direction, but so far, 45% votes. And soon we'll end the poll. We have 5 seconds to go. Okay, so we can end the poll here. Great. So this is how we've responded to question number 2, and 86% believe that many clients with HBV are not eligible for ARVs. And we have a 9% of participants who has gone for A, that in HBV treatment, ARVs don't prevent transmission. And followed by D and B with the same percentage of 3%. Dr. Michael, kindly highlight more on that. Dr. Michael? Okay, so Dr. Michael, most likely, Dr. Michael has got a connection issue. And this was the last part where he had mentioned that many clients with HBV are not eligible for ARVs. And that is to the fact that there is an eligibility criteria for one to be put actually on HBV treatment. So we are now going to, before we go to the case of today, we are going quickly to go through what has been in the chat box. We have experts on the subject matter. We have Dr. Effort Sinkala, we have Dr. Rokaya, and Dr. Wamundila. Yes, thank you. So we have the first question for Dr. Onoya. How to explain the HIV discordant status in a couple that is having unprotected sex? The same question stands for HIV, HBV negative children from a positive mother. Are they underlying and predisposing factors to the vertical transmission? Dr. Sinkala, Dr. Rokaya, one of the experts, may you kindly clarify on this one?
Hello, Dr. Kawana here.
Yes, Dr. Kawana, please kindly go ahead.
Okay, sure. There's some feedback though, I don't know, but I'll go ahead. So when the question says, are there predisposing factors to maybe mother to child transmission for hepatitis B? Yes, they are. I think what we know, and I think Mike partly touched on this, even in the chat box, as a response to the question. So we know that, for example, a mother who has a very high viral load to hepatitis B, more than 200,000 units per mil, has extremely high chance of passing over the virus to the baby, especially at birth. That's one predisposing factor, a high viral load, which is I'm sure same with HIV. The other predisposing factor is e antigen positivity. We know that from the simple biology of hepatitis B virus. We know that when one has hepatitis B virus, and if you look at one of the markers, which is called hepatitis B e antigen, that marker denotes or tells us how infectious a person or this particular person may be. So if they are positive, so if a mother is e antigen positive, again, there's a high likelihood that they are likely to infect others. And so that's why if you look at our local guidelines that were released in 2019, we also use e antigen positivity in a pregnant woman as another indicator for us to start treatment to prevent mother to child transmission. Why? Because we know that then there's a higher risk that this mother may pass on the virus to the child at birth, especially. So in a nutshell, those are the two well-recognized predisposing factors that what that may make a mother easily transmit to a child: a high viral load and e antigen positivity. Over. Thank you.
Thank you very much, Doc, for the clarification. I hope, Dr. Onoya, that answer your question. We have another question from Webster Chewe, and this also was actually tackled. Unless if there is a follow-up, you can kindly raise your hand. We have another question from Chileko Mapiki. For how long is HBV treatment and which antiretroviral combination are advised? Any first line, secondary recommendation? So basically here, Chileko Mapiki was actually wanted to find out for how long are we providing HBV treatment? Our subject matter experts, please, can we have a response?
I kind of tried to answer that question. I've commented on that in the chat box. So this is Dr. Jinwala. So in general, treatment is usually lifelong, similar to HIV. Most patients have to carry on the treatment for life. There are very few patients who may lose their surface antigen and qualify to stop treatment. And even then, the treatment is only stopped after a long-term follow-up with repeated check of the hepatitis surface antigen. So in general, similar to HIV, treatment for hepatitis B is also lifelong. And someone has asked also about which ARVs. It's this. Dr. Mike talked about it, which is tenofovir is the drug of choice. In our setting, we have it as a combined TDF3TC. So tenofovir with lamivudine. Thank you.
Thank you very much, Doc.
Maybe just to add to what Dr. Jinwala has ably said. So I saw on the post that 3% of our listeners or the spokes thought that there is no treatment for hepatitis B in Zambia. So I think it's an opportunity for us to actually inform the colleagues that thought like that actually there's good news that the treatment for hepatitis B is more than available in Zambia and it's for free. And it is like Dr. Jinwala has mentioned, TDF, tenofovir. And of course, we don't have a tenofovir as a standalone, but we still give it even as combined, the Truvada, the tenofovir and the lamivudine. In fact, now we even have TAF, so there's been even other cases where people have been given the same. So those are very important. I mean, there are many other drugs that one can use in the treatment of hepatitis B, but I think for us, our first choice, which is a very potent drug, is a TDF-based treatment. So Truvada is available. It's free everywhere. I think there's no facility in Zambia that will say they don't have Truvada. So I think that was an important observation for those who thought, the 3% who thought that there's no treatment. It is actually available, and let's not deprive patients that may need the treatment on the pretext that maybe it may not be there. And then just secondly, to also add on how long do you treat? Essentially, it's important that when you have a patient who has hepatitis B, you want to find out, are we dealing with an acute case of hepatitis B, or are we dealing with a chronic case of hepatitis B? And whatever the answer, then you look at the eligibility. Obviously, we may not go into detail now into looking at what are the eligibilities for the two. But if it's an acute case, someone was very okay before, and suddenly they have jaundice, and they come, the liver function tests are in the roof. The hepatitis B is positive, and then when you assess them, they look confused, which is what we call hepatic encephalopathy, or maybe they are showing signs of bleeding under the skin. So even if it's an acute case, when there are such indications, those have to be treated as well. But for acute, obviously, you can repeat after 6 months and see whether or not they will have now cleared, because for acute, usually they clear before 6 months. For those who have chronic infection, meaning they've had it more than 6 months, you also want to look at eligibility. And I think just one important thing to stress here is that if a patient has chronic hepatitis B and they have evidence of liver cirrhosis, which you can define, which you can diagnose using, for example, simple imaging like an ultrasound, you find there's ascites, you find there's a small shrunken liver with irregular margins. Yeah, for those where, as I saw someone in the chat commenting about APRI score, we also use APRI score as an indicator for, to see whether there is cirrhosis or not. And we use an APRI score usually for now of more than 2. So if someone has a liver cirrhosis, evidence of liver cirrhosis, the take-home message is that when you start treatment, the treatment is for life. So from the beginning, you cancel them as such. Even for those without liver cirrhosis, but they've met the eligibility criteria for treatment, it's important that we cancel them, that this treatment may be lifelong. However, there are about 1 to 3% of people that can seroconvert, or that can move from having a positive surface antigen to having a negative surface antigen. Usually what we do is we then repeat the next 6 or 1 month, 1 year. If it is still negative and the liver function test is okay, they are clinically very fine. In such cases, then it is recommended that you can stop the treatment. But stopping the treatment does not mean stopping follow-up. Even those who've seroconverted and you've stopped the treatment, it's important that you still continue following them up, because sometimes they can flare and get sick. So I think that was the addition I had. Thank you. Over.
Thank you very much, Doc, for having it been explained clearly. There are still some interesting questions in the chat, which would love maybe to provide a few responses before we go to the case for today. So we can actually respond this question from Mapiki, who was asked to clarify on eligibility criteria. And as well, there is also this question from Melody Banda, who is asking if we can replace lamivudine with entrectinib in case where lamivudine is not available. So can we have a response to this, Dr. Rokaya or Dr. Wamundila?
Okay, I think the treatment, whether you use entrectinib or lamivudine, is not the treatment of choice is TDF or TAF. So whether it's combined with lamivudine or entrectinib, it doesn't really matter, as long as we have the TDF component, the tenofovir component, which is the actual treatment. Lamivudine on its own can also treat hepatitis, but there's very high rates of resistance. So within about 3 years, you get resistance to lamivudine. So we don't use it on its own, but combined with TDF or TAF, fine. So whether it's entrectinib or lamivudine is fine.
Thank you. I hope next week your questions have been answered successfully. Unless if there is any burning issue, you can still raise your hand and ask your question. Can still raise your hand and ask your question.
So Doc, maybe just to answer the other question on eligibility, wow, it's a big topic. It's a topic on its own, rather, not necessarily big, but it's a topic on its own. However, maybe I could summarize to say in the assessment of whether a chronic hepatitis B patient is eligible for treatment or not, we look at mainly things like liver function tests, and for liver function test, we use the threshold of anything above 19 as being abnormal for females, and then 30 for males. So if a female who has chronic hepatitis B comes and you do liver function test, and the liver function test is above 19, and then maybe 3 months later you repeat, it's still also even higher, well above 19. That's concerning. That is called persistent elevation of ALT. So that can be used as a criteria for initiation. In environments where you are able to do a viral load, that's a second criteria you can use for eligibility. So again, those with a viral load above 2,000, if the E antigen is negative, that is considered significant. Then for those who have an E antigen that is positive, a viral load of more than 20,000 is considered significant. Then the third criterion you can use is basically, like we said, an ultrasound. You do an ultrasound and you find there's evidence of liver cirrhosis. That is straightforward, you start treatment. Of course, the easiest criteria is where there's also co-infection with HIV. So that's why we always advise any patient you find as hepatitis B, quickly do an HIV test. If it's positive, then you know they already meet the criteria to treatment for both. And then in centers where we can't do a viral load, but we can do full blood count and we can do liver function test, then we can do what is called an APRI score. If the APRI score is more than 2, again, that may indicate to be another criteria for initiation of treatment. So I think in a nutshell, those are some of the factors we look at. How is the liver function test? Is it above 19 for females, or is it above 30 for males? How is the HIV test? Is there co-infection? It means they qualify. Is there cirrhosis by using the APRI score of more than 2, or fibroscan if you have, or an ultrasound showing features of cirrhosis? You initiate treatment.
Sorry,
so I think the bottom line is let's not delay
one
the
last one which you didn't mention is the strong family history. If somebody has his family history of hepatitis B, hepatocellular carcinoma, so a family history of hepatocellular carcinoma, and they test positive, we immediately do start treatment.
Thank you, Dr. Jinwala. Indeed, in our environment, that's why we realize most of the patients we started on treatment, when you probe further, you find that they have a very strong family history of liver cancers, probably due to the same hepatitis B. So those are at high risk of progression to a malignancy. So you want to treat them as quickly as you can. So I think those are some of the eligibility criteria that one can look at. Thank you. Over.
Thank you very much, our subject matter experts, for this, for making it quite clear to the network. So at this point, we are going to have our case presentation for the topic we are discussing today. So this is a female, 33, a resident of Lusaka, married with household income of above 3,000, a mother of 2 children. The first one is age 6 and the second one 4 years. Pregnant at 36 weeks. And this is a client who is Lusaka based. So she's on TLD and no history of able medication. At the time of review, this particular client had no complaint, and this particular diagnosis of hepatitis B was actually made during antenatal at the local clinic, and later on she was referred at UTH for further management. She's RVD-ARA. She's actually on a TLD since 2018. The husband is actually discordant, HBV discordant, no diabetes, no TB, no epilepsy, no alcohol intake. On family history, we have hepatocarcinoma history in the family, and we do not have any hypertension, TB, diabetes, and elicitation of siblings not yet done. Though the sexual contact had notified that he was negative on HBV, but already on HAT on ABC3TC DTG. So on physical examination, this particular client is stable. We didn't really have any particular concern on clinical examination. So the lab results, so on the 11th November, that was 2021, hepatitis B antigen was reactive, C non-reactive, and the urea and creatinine, those are the results we are having, 4.3 and 43 millimole per liter, that is for urea, 4.3 and 43 for creatinine. So the ALT and AST, for ALT we had 21.3 and AST 28.8 international units per liter. For HBV viral load, we had no DNA detected. For HIV viral load, we had targets not detected. So the platelets on the 11th, on the 19th November, it was 238, and the client was on TLD as the ART regimen. On the 24th of June this year, creatinine was at 94.7, ALT 19.1, international, unit per liter. AST as well, we had 26.6. So on the DNA not detected, and this particular client, as the HIV viral load, we had targets not detected. Platelets was not done, and the regimen remained the same. So now our question, how do we manage HIV, HBV better in this client? That is number one. Secondly, what will be our follow-up action to the sexual contacts and other household members? And our question number three, what preventive measures do we put in place in regard of our pregnancy? So these are the questions we are having for this particular client on the subject matter. So if we have questions concerning the presentation, we can still raise our hands so that we have it clarified. So I'll repeat again, just briefly. So a female, 33, of Lusaka town on TLD, actually HIV positive on TLD, with 2 children currently pregnant, and with an history of hepatocarcinoma in the family, elicitation of sexual contacts not yet done, though the husband notified that he had done an HBV test, which came out negative, but on HIV is already on ABC3TC DTG. Clinically, there was nothing significant, and the client was stable. So the lab result is the one we have mentioned here. This particular client has HBV results, targets not detected for HBV as well as HIV viral loads. The regimen the client is on is TLD, both last year on the 19th November, as well as this year on the 24th June of this particular year. So our questions is to know if we have a way we can do better in managing this client, and secondly, a follow-up action on the sexual contact as well as other household members, and lastly, what do we do as preventive measures to in regard of our pregnancy? network, we need your participation with question 1. How do we manage this client better? Chipata Centro, how do we manage these clients better? St. Francis, you can as well chip in.
Maybe we should ask, are people happy with the way this client was managed?
Okay. Dr. Ginwala, maybe you may kindly repeat your question so that everyone can
I
get
was
it.
saying maybe we can rephrase that. Are people happy with the way this patient was managed? Because they're asking, should it be better? Are they happy? Was it better? Was there anything more that could have been done, or people are just happy?
Yeah. Okay, so are we comfortable with the way this client was managed? We have Chilonga Mission Hospital in Muchinga province, where we are saying Chilonga is actually giving a response to say the client was well managed. Okay, so Chilonga, you've answered your first question. Okay, so we have Sepiso. Please, Sepiso, kindly go ahead. You've raised your hand.
Okay, thank you. This is Sepiso from Sesheke. I just wanted to talk on the second question in terms of follow-ups of sexual contacts. From your presentation, you mentioned to say the husband is negative on hepatitis. Yes, he may be negative, but there will be need to repeat the test. Maybe the antigen antibody reactions are not yet full. So we may need to repeat, and also we may need to screen the parents, because for this hepatitis may take long for someone even to get having symptoms of hepatitis. So we may check the family history, and also just to screen the parents if they had hepatitis. Then also this hepatitis can be transmitted in many ways, as we know, even sexual. So this mother should also be followed up in terms of index. You said we need to index this mother. We need to follow the mother and the index further. Maybe she could have some other sexual contacts who can transmit this infection to her. Then just I touched a little bit on question 3. Yeah, this is a mother who is pregnant. So the transmission to a baby is very, very high. So we may need to give immunoglobulin to this child immediately she's born. I've just forgotten the timing, but I know that the first dose will be given is it within 6 weeks, and then we need to give another one. But we may guide on that one. Thank you very much. I submit.
Thank you very much, Sepiso, for the comments given. Actually, you've tackled question 2 and question 3. Any other addition to the subject matter?
Hi, Dr. Ngoma. Let me just to add on by way of clarification also from what I think should be Sepiso just mentioned. So indeed, the care package for a mother, a pregnant mother or woman, and has hepatitis B, doesn't end at the mother or the woman alone. But as we already start looking after such clients, we also have to have the baby in mind. And the recommendation is that we already start preparing the mother that at the time they give birth, where resources allow, two things should be made available for the sake of the baby: the vaccine and the immunoglobulin. In terms of the timing, I think the episode was mentioning 6 weeks. That's very late. In terms of the timing, it should be within 12 hours, or preferably using our local guidelines, it says within 24 hours. So the same day the baby is born, within that same one day, you should have already given that baby 0.5 news of the vaccine. And then also you give the baby on the thigh, and then you can also give the baby the immunoglobulin if it is available on the other side of the thigh. Why are we emphasizing if available? Is because we know that immunoglobulins for hepatitis B are not available in the government institutions. So that is why I was saying care package, meaning as you are seeing these clients, already start preparing them for birth. And some of the clients may have the resource to buy these immunoglobulins, but because there's been no information, they don't prepare for birth. But the vaccine usually is very affordable and quite available. And so if there's no immunoglobulin, at least one can prepare to give the vaccine at birth. And then, of course, they then can continue with the usual pentavalent vaccine, where there is also hepatitis B at 6 weeks, 10 weeks, and 14 weeks, as we do in our under 5 clinic, since we haven't effected yet the birth dose. But I think that's the take-home message in terms of the preparation for the baby. So it should be given within the first 24 hours, the vaccine and the immunoglobulin, if available. Over.
Thank you very much, Dr. Wamundila, for clarifying this point. I think we have taken note of what is expected from us. Dr. Rokaya, do you have a point to add?
I'm looking at the time, and I just wanted us not to ignore question 1. Okay. I think people are quite happy that they were managed well, but I just want to remind you that this woman was tested in pregnancy, yet we knew she was HIV positive. A lot of times we are missing hepatitis B because our HIV program, we are not routinely testing for both. So it's very possible, especially with that family history of hepatocellular carcinoma, that she's had hepatitis all along, but we only picked it because she was tested in pregnancy. So just a reminder that we should be, it may look like she was managed well, but just remember that when we see HIV patients, we should be also thinking about both testing for HIV and hepatitis B. She would have been picked up earlier.
That's very correct, Dr. Okaya. Actually, there were some good missed opportunity on the hepatitis B testing, which was actually not done. And more effort was given to the HBV instead of the HBV viral load. Instead of it being done yearly, it was actually done in a period of 6 months, which is somehow costly also on the part of this client. So that is actually a very good update on this subject. So there is also a question as we are winding up on the platform. What can be the best substitutes for TDF if the patient had renal insufficiency? So what can we substitute in case TDF is contraindicated? Can we have a response to this?
Yeah, so actually someone mentioned that also in the chat. So as you may be aware, that it's well documented that among some of the potential toxicities to TDF is renal insufficiency. And that's why when we put clients, either HIV or hepatitis or co-infected, part of our monitoring package is to be checking the renal function test. So where we start seeing tendency of some toxicity, usually it's advisable and recommended that we can actually switch if we have alternative like tenofovir AF, the TAF, that is if the clearance, of course, is below 50, but up to about 30. Then also it depends if the patient is mono-infected and has the significant kidney, maybe let's say chronic kidney disease, and maybe one is in a facility where maybe issues of dialysis may not be easy. It's also recommended that, of course, with expert consultation, that these patients who are mono-infected with hepatitis B may be given TDF still, but probably not on a daily basis, maybe bi-weekly. But I'm putting a caveat there with consultation, with the experts. So those are some of the options that we may have, either switching them to TAF, especially for this one who was called infected. But if it was a case of HBV mono-infection with significant renal dysfunction or a CKD, we also have other options where we look at instead of a daily dosing, we can do bi-weekly. Then also just quickly to comment, I think there was a question also on hepatitis C in the chat to say what treatment should be given. So hepatitis C has several drugs that we use, though not available in the country. So most times when we confirm that someone has hepatitis C, remember that hepatitis C is different from B. Because with hepatitis B, once your surface antigen is positive, we take it that one is infected. But with hepatitis C, if the antibody test, which is what we use as a first line, is positive, doesn't necessarily mean one is infected with hepatitis C. So if the antibody is positive, you have to go to a confirmatory test, which is the viral load for RNA. So if the viral load for RNA for Hep C is positive, then that client has hepatitis C. And the common drug that is used, usually which cuts across all the genotypes, about 8 of them, is sofosbuvir based treatment. So sofosbuvir and velpatasvir. So those are the ones that we always really recommend. We have had a few patients actually who we have put on treatment based on those. I think those are the things I thought we should mention on because they were put on the chat. Thank you.
Thank you very much, Doc, for responding to these concerns with clarity. So as we are wrapping up these 3 questions, what we've learned from the comment is that we had managed well this client. The missed opportunity is that we're supposed to diagnose this hepatitis B quite earlier than at the antenatal clinic, looking at the history of hepatocarcinoma in the family. And we are also supposed to take note that viral load for HBV is actually done yearly than the way it was done in a period of 6 months. We have also learned on question number 2 that all the sexual contacts need to be followed up and be tested so that we have a clear picture. And the household members are supposed as well to be tested. The same approach for index as it was mentioned in our didactic today. So what we have also learned in preventive measures in regard of her pregnancy, as soon as she delivers within 12 hours, we need to ensure that we give this particular child a vaccine. So basically, that is what we've learned from this case.
May I add one last comment? Sorry.
Yes,
just to say, apart from the household members, we want to contact all, follow up all the siblings because of the family history for question
Yes.
2. And then for question 3, prevention, I'm not sure if we mentioned anything about the husband. Was he vaccinated? If he's negative, then this is an important time to ensure that he gets vaccinated to prevent himself getting infected as well. Thank you.
That's very good. That is quite great, Dr. Rokaya. So basically, that is what we've learned today. Dr. Wamundila, just maybe in 30 seconds.
Dr. Mongomba, just
Yes.
sorry for interrupting. On the viral load, you mentioned that to be done yearly and not 6 months. But if she's pregnant, it's supposed to be every 3 months, just for those who are on the call.
Okay.
Over.
Thank you, Dr. Sinkonde, for that clarity. That is quite much appreciated. Dr. Wamundila, can you please kindly conclude in 30 seconds on what we've learned today?
Yeah, so I think in 30 seconds, maybe for me, it's just to say, let's all be champions of a treatment of hepatitis B. Let's take advantage of every testing opportunity to test people with hepatitis B. And then also remember that if you are following up a pregnant woman with hepatitis B, prepare not only for the mother, but prepare for the baby. So start counseling them about securing the vaccine, and if they can manage also the immunoglobulin in advance, so that they can have them ready, prepared the moment the baby is born. Within the first 24 hours, they should receive the vaccines and the immunoglobulin. Thank you.
Thank you. Dr. Michael, are you on the call now? Okay, Dr. Michael is not on the call. Thank you very much for your participation. I hope all of you have actually registered your presence to this meeting. The link was actually shared on the chat. So thank you very much for your attendance. We can sign off.